كده باين ان احنا we're recording.
بالظبط كده.
تمام.
احنا كده هنلونش الويبينار. اوكي يا جماعه؟
تمام.
اوكي يا دكاتره، اتفضل.
برضه احمد
احنا
لو
دلوقتي
ممكن يبدا ريكوردنج ولا هو واحد بس هو اللي بيريكورد؟
لا ممكن اكتر من حد. انا هكون بريكورد، لكن علشان ما يكونش واحد بس اللي بيعمل الريكوردينج، بس يبقى واحد وواحد باك اب. تمام، احنا ممكن نبتدي دلوقتي عشان ما نتاخرش على الاودينس.
تمام.
اوكي، احنا هنبتدي في 5 ثواني.
Okay. Just a few seconds كده. I'm looking at that وبعدين Okay. طيب, good evening, everybody, and welcome to our bi-monthly CUPS meeting. We are very honored today to have our iconic Dr. Gehad Elnahri as our moderator and our very distinguished Dr. Maha Yusuf also as our moderators for some very interesting cases, and I hope you enjoy it. We're going to start off with our resident, Christina. So Christina, can you share your screen, please?
Great. Good evening, my dear professors and colleagues. I'd like to share with you today a case of Plexiform and neurofibroma. Can we help? We have a child of 4-year-old. She has a left upper leg swelling and a globe displacement, and the mother noted that since birth, but she noted a gradual progressive growth over the 4 years. And when we asked her about family history of a similar condition, she denied. We have a child of, she has an upper leg swelling in the left eye and dystopia, intranasal dystopia, and ptosis. When we looked for the blepharoptosis, it has a characteristic shape deformity, and also she has involvement of the temporal region or infiltrated with a soft tissue swelling with overlying skin pigmentation. Regarding the dystopia, she has an infranasal displacement, a vertical inferior displacement about 7 millimeters, and nasal displacements about 3 millimeters. When we did the ophthalmic examination, she has a significant anisometropia. She has myopia in the left eye and myopic astigmatism of -5.75 with oblique axis. And the best corrected visual acuity in the right eye was 6.6 in comparison to the left eye that was 6.12. The anterior segment was normal in both eyes, and the pupil was reactive in both eyes, no relative afferent defect found. But in the fundus, there was a cup disc ratio of 0.5 in the left eye in comparison to the normal size that was 0.2. The IOP was with normal range in 2 different occasions, and the extraocular motility was limited in the left eye, limited elevation and abduction only. We asked the mother if she noticed any pigmentations all over the body, and she said yes, she has this kind of pigmentations, and obviously it was a cafe au lait patches over the trunk. It was more than 6. And this mother sought medical advice elsewhere when she noticed the growth of the swelling, and she was like diagnosed as a lymphovenous malformation and directed to our hospital for radiological intervention by injection of sclerosing agents. But when we revised the imaging, we'll find that there's actually infiltration of the orbit in the lacrimal gland region and also the temporal region of soft tissue swelling. And two, the sagittal cuts show defect in the greater wing of sphenoid. So it's not lymphovenous malformation as was thought previously. Here is infiltration of temporal and lacrimal gland area and also the greater wing of sphenoid defect. The soft tissue too, the MRI too show that there is no infiltration of the optic nerve itself. There is no tumors of the optic nerve itself, but the temporal loop herniates into the orbit. Here's this cut show to herniation of the temporal pole into the orbit. The same here. So the optic nerve pushed forward. So we have 6 or more caveoli patches, and this obviously is not a lymphovenous malformation, but actually it's a plexiform neurofibroma. And we have a sphenoid dysplasia. So that's enough to diagnose neurofibromatosis type 1. The criteria of diagnosis, it just need 2 or more of the following list to diagnose neurofibromatosis type 1. So here, regarding this plexiform neurofibroma, the swelling that the mother came complaining from, it's better to term it as orbital, periorbital plexiform neurofibroma as suggested by the American Academy of Ophthalmology. It's a Schwann cell tumor grow along the distribution of 1 or more of branches of the trigeminal nerve. And sometimes it's just isolated in the lid, or it involves the periorbital region too, that may go into the orbit. And when it starts with the orbit, it may infiltrate into the cavernous sinus. And in some cases, it's associated with the sphenoid dysplasia. And the growth rates more in childhood, and it becomes minimal in adolescence and adulthood. So in this girl, we have 3 issues: the amblyopia in the affected eye and the vision loss. We have the disfigurement. We have if there is an association or any malignant potential in such case. To look for the causes of the vision loss in this patient for the amblyopia. It's a refractive amblyopia. She has anisometropia. The anisometropia here is induced by ptosis or increased axial lenses. That's documented in some cases. We here just needed to measure the axial lens in this patient, but she missed her follow-up for this point. Also deprivation amblyopia because of the ptosis, and amblyopia due to strabismus. Also glaucoma. Glaucoma here have different mechanisms, maybe infiltration of the angle by the neurofibromas. It may be an angle anomaly from the start. It may be fibrovascularization. And to the issue of the optic nerve compression, whether by the plexiform neurofibromas or later if they develop gliomas, and exposure keratosis if there is a significant proptosis. We here in this patient, we have anisometropia due to ptosis, yet we have pushing over or compression over the optic nerve. We check the angle of the patient. This is the right eye, the normal side, more or less it's a normal trabecular meshwork, normal angle recess. But in the left eye, we have like a membrane over the trabecular meshwork in around half of the angle. Yet the IOP was normal. We checked for the OCT macula to see the retinal nerve fiber layer. It was difficult in this patient to do an OCT optic nerve head due to improper fixation. But here, the retinal nerve fiber layer in this in the right eye, in the left eye, grossly, it looks thinner, and yet we needed to do like measurement, accurate measurement, but it was impossible in this patient. What about the malignant potential? This patient may develop a malignant peripheral nerve sheath tumor that grow over the plexiform neurofibroma. We become suspicious that if it's progressive or there's a persistent pain, rapid growth, and here the surgery would be the first treatments. Also, these patients have potential for other malignancies. Most important is the malignant glioma. So what we do for this patient? First thing, this patient, when she sought medical advice, the first one who saw her was ophthalmologist. But we have here a systemic condition. So our role here is not only just to diagnose or to deal with what's related to the eye, but also she needs a multidisciplinary approach. She needs to go to pediatrician. She needs a neurosurgical consultation. And also the patient may not know the name of the disease. If we know the multiple sclerosis patient, many of them, whatever their educational level, they can say they have MS. So whenever they go to any physician, they will say they have this disease. So what about to tell the patients she has an NF disease? So regarding ophthalmology, we have the problem plexiform and neurofibroma now. Later on, she may have an optic pathway gliomas, brainstem gliomas. About the multidisciplinary approach, the American Academy of Ophthalmologists, there was a workshop or a task force, what's called task force workshop in 2013. They suggested some measures to help these patients. So when we examine these patients, how we will follow them up, how we will do the imaging, will we do any surgical intervention, and what about the non-surgical intervention? The imaging in a patient we suspect a plexiform neurofibroma, we have to do an MRI brain orbit and involving the cavernous sinus, cuts involving the cavernous sinus to see if there's any infiltration there. When we will follow up, how many times we'll do MRI, yet there is no consensus regarding this, but if there is gross suspicion of malignant transformation, any change of the symptoms, we have to do it. We will do a debulking for it. Yes, it's well known that any surgery or debulking for this plexiform neurofibroma, it's difficult to remove. It will recur over time. It will grow again, especially in childhood. So debulking is only referred to the patients that have a compression over the optic nerve. Other issues can be addressed with surgical intervention, like if there is a nasolacrimal duct obstruction, any other tissues. Bone defects, some evidence says there may be a bone grafts for the bone dysplasia, yet when we did a neurosurgical consultation here in this child, they suggested just to follow her up, and really it doesn't work to do intervention for her now. If there is a strabismic intervention, it would be the rate, also because of growth of the disease, growth of the mass will lead to unpredictable results too. So what's important here in this child, what we can help her in, first of all, is we were her window for medical care and the multidisciplinary approach. We can refer her to other specialties too, and we can follow her up. And the amblyopia therapy here regarding giving correction, patching, and to follow up if there is a development of glaucoma over time. Whether by the IOP in examination of the angle, and also to check if there is no more compression over the optic nerve. And here, if there is elevation of the IOP, it will be like multifactorial affection of the optic nerve. We started with giving the patient the amblyopia therapy, and we managed to follow her up and to see if other specialties will help her. To sum up, so we have to see her at least every 6 months. Surgery is not the first option unless if there is compression on the optic nerve, and to treat everything like the glaucoma, and we can trace the ptosis if there is like severe ptosis, but after stabilization of growth. Thank you.
Thank you, Christina. Very informative. I would like to ask Dr. Gehad and Dr. Maha, they would like to ask anything about this case or share their views on this case.
The first thing I want to comment on هو في some missing for reporting. يعني we must always talk about the pathogenesis of the disease وإنه genetic وإنه autosomal dominant. We must examine the father and the mother. One of them must have evidence of neurofibromatosis. If he doesn't have neurofibromata او plexiform, هنلاقي فيه كافيه اولي باتشز، او هنلاقي فيه another sign that was missed in this case, which is leash nodules. Leash nodules of the iris are present in 100% of cases, so they must be present in this child. طبعا, as Christine said, the case is very difficult to manage. There are multiple problems, not only lid neurofibroma, plexiform neurofibroma, but also orbital involvement, dysplasia of the greater wing. هنا dysplasia of the greater wing is a curse and a bless لأنها it's a form of orbital decompression. وبالتالي the effect of pressure of the neurofibroma on the orbital structures in the optic nerve will be decreased by the presence of this extra space at the back of the orbit. فglaucoma is not very likely. We should measure the corneal diameter in order, because if it is glaucomatous, it could present as an infantile glaucoma and start early in life, but the case does not look to me as having large cornea or as a case of ophthalmos. In angle, there is an anomaly, but it seems it didn't include 360 degrees. That's why the intraocular pressure is still. There is an increase in cup disc ratio, but in the absence of a field of vision or OCT of the optic nerve head, it will be very difficult to judge the cause of this increased cupping. It could be anomalous disc because of the anomaly of the region as a whole. It will need follow-up for the suspicion of glaucoma. As she said, management is difficult. I do remember there is a drug, a new drug for the management of the بس أنا I don't recall إذا كان في حاجة كده. Did she search the literature for such a drug?
Yes, there was mitogen protein kinase inhibitors. I can't remember the exact name, but under development.
يعني we hope it proves to be of efficiency or promising in the treatment of this يعني notorious disease. But cosmetically speaking, it's very difficult to manage. The lines of management you proposed are the right ones. You will protect the eye from the effect of amblyopia until the disease quietens, and then you can manage the strabismus by surgery if it's possible. Thank you.
Thank you, Dr. Maha, would you want to ask anything? Okay, thank you, Christina, very much. Our next presenter is our resident, Abanoub. You can share your screen.
طبعا we all know that neurofibromatosis is two types, type 1 and type 2, and they are part of the phacomatosis diseases or generalized phacomatosis, in which there are multiple swellings in the neurocutaneous regions. The protein involved is neurofibromine, which is coded by chromosome 17. So the genetic defect is on chromosome number 17. اتفضل يا أبانوب.
حاضر. هو أنا بس في عندي مشكلة في الشريط.
تمام، احنا شايفين يا أبانوب.
Good evening, dear professors and colleagues. We will today talk about a case come 5 days ago in our clinic. Female patient, 2 years old, complaint of acute loss of vision the day before she comes at night. By examination, visual acuity can't fix or follow. Intraocular pressure 10 bilateral. Cornea by examination was clear. By staining, no ulcers. AC formed, no abnormal content. lens clear, no vitreous haze, but retina by this picture bilateral extensive vasculitis affect الveins more than arteries في retinitis, dot hemorrhage, cotton wool spots, bilateral hyperemic disc. The other photos.
معلش, how old is she?
2 years.
2 years.
By examination, there was 1 week before the event, she was fever, she had the tonsillitis, received Cefotex IM, Brufen syrup. By examination, the head and neck, there was oral ulcer في tongue and lip, cervical lymphadenopathy, and no CNS manifestations, no history of convulsions, disturbed conscious level. Chest, I refer to the pediatric by examination, يعني chest was clear, heart normal, abdominal examination was normal. By examination genital system, there was a labia minor infantile hemangioma, upper and lower limb were normal. No signs of immunocompromise by asking about recurrent fever, recurrent illness, about her mother, about her father, all was normal. البوزيتيف داتا بالنسبه لنا acute loss of vision والفاندس بيكتشر والفيفر 1 week ago والاورال ألسر والليبيا ماينور هيمانجيوما. يعني suspect ان دي picture of frost branch angiitis, but by searching في literature there is no at this age, يعني all cases reported were about 6 and 13 the majority, and older than that, like in 2 years we don't يعني we can't find a case like that. بالنسبه لنا كان الديفرنشال دايجنوز فيروس ريتينايتس سيتوميجال فيروس او هيربس سيمبلكس او اوتو اميون ام اس او سيستميك لوبس او بهشات او ساركويدوزس او لوكيميا او ليمفوما او تي بي او سيفلس او ايلز ديزيز. البيدياتريكس كانوا بيسسبكت ان هي حاجه اوتو اميون وكان عايزين يبداوا ستيرويدز، طبعا وي ريفيوزد. اول حاجه عملناها ان احنا البيشنت دي عملنا لها هوسبيتال ادميشن وبدانا سايكلوفير اي في immediately once ان هي admitted in our hospital. يعني عملنا لها لابس سي بي سي was normal. الكيمستري all was normal except the ESR was 100 first hour and second hour 115. الهربس سيمبلكس والسايتوميجال والاتش اي في بي سي ار is pending. We did the neuro consultation. She asked for MRI. We did it, was normal, but we consult infectious disease, ask for CSF aspiration, but pediatrics and neuro refused and told us she has no CNS manifestations, refused انهم يعملوا CSF. We ask about steroids. في الليتريتشر كان بيريكومند في بعض الناس بتريكومند ان احنا ندي ستيرويد تو افويد الماكولار سكارينج وانس ان احنا اكسكلود اي اميونو سبريشن. second thing ان احنا intravitreal injection of ganacyclovir or not. Some cases improved, but some cases developed endophthalmitis and CSF aspiration or not, or any other recommendation. Thank you.
Thank you, Abanoub. دكتور جهاد مها
بقى تعلق.
حاجة يعني I think that patient we should يعني can close up more يبقى more detailed than this. يعني should search for a cause for being immunocompromised. يعني how she will get cytomegalo if cytomegalo يعني from the start she should be immunocompromised. Does the patient look healthy برضو أنا فكرت في حاجة بس the fundus picture is not like that بس what about the endogenous endophthalmitis patient was having fever, tonsillitis? What about the blood culture? Does she have any urinary tract infection? Cytomegalovirus, I think the frosted branch meningitis for cytomegalovirus has been described for the immunocompetent children, but not that age. Frosted branch meningitis cannot cytomegalovirus has been described in immunocompetent without being immunocompromised, but not that young, not 2 years old.
blood picture already we did. مفيش اي signs of UTI او urinary tract infection. بالنسبه للimmunocompromised by history and الديفلوبمنتال بتاعها and مفيش اي signs of fever، مفيش اي signs of recurrent fever. her mother is very well. مفيش اي signs of اي حاجه immunocompromised. وان الفيفر دي once حصلت واخر يعني حصلت بتقول لنا اخر مره حصلت لها من 3 شهور ومش عاده بتسخن ومش عاده بيحصل لها الكلام ده. ولما دورت في الفروست برانش انجيتس لقيت ان في بعض الحاجات باسك بس ما كان مش في السن ده، يعني اقل حاجه من 6 to 16 years ومور ان جابان، لكن ما لقيتش حالات دوكيومنتد ان هي اقل من 6 سنين.
ممكن نشوف صوره الفندس تاني اللي انت طلعتها دي.
أبانوب، هو انت بصيت على العينه دي؟ sorry, did you have another look after they started the IV?
نعم.
Did you look at the fundus again after they started giving IV antiviral?
هو الفيجن today improved، يعني today الفيجن بتقول لي ان هي بدأنا الاسايكلوفير من 5 days، بتقول لي النهارده ان هي بدأت تشوف خيالات، ان هي مامتها بتقول لي ان هي بدأت ان هي شايفه
ما اديتش انترافيتريال اسايكلوفير ليه؟
احنا we looked for it فعلا يا دكتور جهاد.
انا من الاسئله اللي انا كاتبها لحضرتك هل ده سايكلوفير اور نوت، واحنا كده مش لاقيينه برضه يعني.
This is a case of bilateral acute retinal necrosis. ده مش frosted branch meningitis، ده acute retinal necrosis. herpetic most probably in origin. فطبعا كويس اللي انت عملته من ناحيه ان انت اديت انترافينوس سايكلوفير، بس كان يفضل انك تدي معاه انترافيتريال. طبعا لو تقدر تجيب فالتريكس فلا سايكلوفير هو مور افيشنت عن السايكلوفير في الاكيوت ريتينال نيكروز. فلو عرفت تلاقيه حول عليه ودي انترافيتريال فلا سايكلوفير.
تمام.
لكن ده bilateral acute retinal necrosis طبعا very unusual age for برضه acute retinal necrosis. لكن الفروستد برانش ما بتبقاش لا ده التيبيكال ابييرنس بتاعها ولا هي ذات بتبقى ذات سيفير يعني، ولا ده الايدج ولا ده الاس يعني.
ودكتور جهاد حضرتك كمان السايتوميجال نوت ريسبونسيف للسايكلوفير يعني
هو الاوقع اللي يقدر يعمل اكيوت ريتينال نيكروزس في نون اميونو كومبرومايز هيكون هذا السيمبلكس السن ده. تشيكن بوكس لو مش متطعمه وارد، يعني اقصد اللي هو انها تكون زوستر، يعني لو هي مش واخده تطعيم ممكن، بس يعني ما فيش راش ما فيش، فالاغلب انه اكسيرب السيمبلكس.
الكورنيا
زوستر او سيمبلكس هو التريتمنت واحد، لكن سايتوميجالو هنا احتماله اقل. طبعا الفيرولوجي مهم
اوريدي
يعني بس المفروض يعني دي تطلع بسرعه لانها جايد تريتمنت. لكن يعني
سحبنا لها السيرولوجي وسحبنا لها بي سي ار. البي سي ار هيظهر بعد 15 يوم، والسيرولوجي المفروض النهارده بالليل او بكره.
ماشي. هو كل ده هيبقى يعدل التريتمنت، لكن انت يو هاف تو هيت يعني ايه بيزد اون الكلينيكال فايندنجز، لانك مش هتقعد مستني. وانت ابتديت سايكلوفير which is the right decision، لكن كان ناقصك انك تدي انترافيتريال كمان.
طب حضرتك الاستيرويدز؟
لا الاستيرويدز مش في المرحله دي، مش بعد ما يطلع الفيرولوجي ويكون عدى اسبوع على السايكلوفير ممكن تبقى تدخل استيرويدز. لكن في الفيري اكيوت ستيج دي مع البنت عندها شويه ليمفادينوباثي انت بتقوله اورال السرز وبتاع، ممكن تخش في انكفالايتس هيربيتيك انكفالايتس لو اديتها ستيرويدز.
تمام.
خصوصا بالذات الهيربس سيمبلكس يعني نوتوري ريزل مع الاستيرويدز.
السؤال الاخير كنت بس حضرتك نسحب CSF ولا؟
مش شايف له دور قوي هنا يعني، لانه ما فيش زي ما انت قلت الMRI از نورمال، ما فيش نيورولوجيك مانيفستيشنز، يعني الاغلب CSF مش هيطلع فيه فايندنج تساعدك على حاجه. لو هي بقى يعني ابتدت، طبعا انت ابتديت تريتمنت بالاسايكلوفير، وبالتالي احتمالات انها تبروجرس لسيريبرال كومبليكيشنز او هيكون اقل، لكن لو طبعا العيان ابتدى يبقى ليثارجيك شويه او دراوزي او كده، ساعتها يبقى تعمل CSF اكزامينشن. لكن رايت ناو اتس مور دينجرس عن انها تبقى اوف فاليو.
دكتور
دكتور جهاد، اخر حاجه، هل في اي اليمنت ممكن يكون حاجه هنا اوتو اميون ولا لا؟
لا، ده تيبيكال اكيوت ريتينال نيكروز.
تمام.
دكتور جهاد، الاكيوت ريتينال نيكروزس كبروجنوزس في this age؟
بروجنوزس فيري باد طبعا، بس يعني هو هنا هيبقى الديترميننج فاكتورز هي جت بعد الانست بقد ايه، وهو ابتدى على طول. اصل عاده الديسيجن تو ستارت السايكلوفير ده هياخد له اسبوع 10 ايام انفستيجيشنز، فتبقى الحاله خلاص عدت مرحله السلفج كده. يمكن مع الانترافينس اللي هو الداعي ممكن العيانه يرجع لها شويه يوسفول فيجن بوسيبل، بس طبعا لازم نعرف برضو ان في ليت كومبليكيشنز، وبعد شويه ريتينال ثيننج، وممكن يحصل ريتينال ديتاتشمنت بعد كام شهر، فيعني البروجنوزس دايما جريم.
دكتور
لكن
جهاد،
اتفضل. ليتس هوب انها يبقى عندها شويه يوسفول فيجن.
we have a question from the audience. يعني they're asking إن هو acute retinal necrosis is mainly peripheral while these pictures look like it mainly vasculitis.
لا الاكيوت ريتينال نيكروزس هيبتدي بريفرال، لكن بعد بعد يوم او يومين ممكن تبقى ذا هول ريتينا از انفولفد. اكيوت ريتينال نيكروزس هو لو انا شفته اول يوم ممكن اشوفه بريفرال، لكن مش بعد مرور شويه وقت.
Okay. Thank you. Okay. Thank you, Abanoub. Okay, we move on to.
يبقى انت دلوقتي you continue your acyclovir لحد ما الفيرولوجي يطلع، و I would give at least once لو طلع الفيرولوجي بوزيتيف للهيربس سيمبلكس ادي انترافيترال اسايكلوفير.
انترافيترال اسايكلوفير
فالا او اسايكلوفير، يعني اذا لقى فالا سايكلوفير فالتريكس يبقى يكون افضل، ما لقاش هيدي اسايكلوفير.
اوكي.
Our next presenter is Rana. Rana, can you share your screen, please?
Yes, Dr. Can you see? Okay. Good evening, and I'd like to thank all of the panelists for inviting me to their presentation. My title today is called "If you look for it, then you'll probably find it." We're going to start by discussing the first case about a 3.5-year-old girl that presented with occasional redness and photophobia to my colleague. He diagnosed her as anterior uveitis and started her on topical steroids. When she came to me, I found that the systemic history was active, and on examination, she had bilateral non-granulomatous anterior uveitis with +2 cells. Clinically, at the first visit, her fundus examination was normal and her workup was free. I labeled her as idiopathic and started her on methotrexate. The girl has been beautifully controlled for several months of all forms of steroids, even the topical, until a routine follow-up visit when I discovered that she had a completely white eye, but in spite of that, she had bilateral AC inflammation and vitritis in both eyes of grade 1. In the left eye, she had 2 nodules. So in spite of being a young age and she was very uncooperative during the examination, I insisted that the father does a fundus fluorescein angiography and an OCT, and they told me that it won't be possible except under general anesthesia. I said it will be worth it. Surely enough, the fluorescein angiography showed mild peripheral retinal vasculitis affecting the venules, and it's also anterior to the equator, and it can be appreciated in the OCT, especially in the left eye, that there are some posterior vitreous cells. Case number 2 is a 14-year-old girl that presented to me with recurrent bilateral photophobia and floaters. Her systemic history was free. She was already on topical steroids when she came. Someone ordered a heavy serology workup related to all sorts of connective tissue diseases, including rheumatoid arthritis, systemic lupus, and even Sjogren disease, and all of the serology workup was negative. On examination, we can appreciate the presence of non-granulomatous KPs with cells +1, and she had an IOP of 26 millimeters mercury bilaterally, even though she reported saying that she never had a problem with intraocular pressure before. And on dilated fundus exam, we can see that she has vitritis of grade 1 to 2 with small snowballs inferiorly in one eye. Luckily for this patient, her fluorescein angiography and OCT were both normal. Case number 3, we were dealing with a 12-year-old girl that had recurrent redness and photophobia dating exactly 1 year ago. She said that it was of acute onset and she can pinpoint the exact point when the redness started. She was living abroad, and over there they ordered also heavy serology workup for everything related to vasculitis, such as the ANA, double-stranded DNA antibodies, and the ANCA-C and the ANCA-P. Everything was negative. She has been taking oral, topical, and periocular steroids and started methotrexate 8 months ago. And she was controlled on the methotrexate and stopped all forms of steroids. But unfortunately, she had glaucoma in both eyes, which was more severe in the right eye with an IOP of 33 millimeters. And this happened subsequent to a triamcinolone acetonide subtenon periocular injection. On examination, we can appreciate the presence of some iris pigments on the anterior lens capsule and the presence of significant snowballs. And it's worth noting that the vitritis and the snowballs in this patient was in one eye only. The fluorescein angiography revealed bilateral tortuosity of the vessels, but otherwise the periphery was okay with no leakage from the vessels, and the OCT was normal. We can also appreciate the asymmetric cup to disc ratio, which was larger in the right eye, the glaucomatous eye. Case number 4 is of a 16-year-old female that presented with bilateral redness, photophobia for 2 years. On examination, she had vitritis, but no snowballs, and the retina clinically was free. Someone else has ordered a sacroiliac joint X-ray and ordered HLA-B27 typing, which was negative, even though systemic history was free and she did not complain of any joint affection. Her slit lamp photos shows the presence of inferior posterior synechiae in the right eye from 4 to 7 o'clock and in the left eye at 6 o'clock, and she had a non-granulomatous anterior inflammation. Even though the fundus clinically, the retina clinically appeared normal, I ordered a fundus fluorescein angiography, which revealed that the peripheral vessels showed very subtle peripheral vasculitis affecting the venules anterior to the equator. Her OCT revealed was more or less normal. In case number 5, we were met with a 14-year-old girl. She had recurrent redness and photophobia, but unlike the previous cases, this patient had significant diminution of vision. She reported that previously she has improved dramatically on topical and high doses of systemic steroids. She has been started elsewhere on methotrexate, but she failed it. She wasn't controlled on it. And then she was currently put on 20 milligrams of oral prednisolone as well as azathioprine. In spite of these 2 therapies, in addition to 4 times daily of topical prednisolone, the patient still had active inflammation. Unfortunately, in this patient, unlike the previous cases, she had evident disc edema, which showed late leakage on the fluorescein. And in addition to that, she had inferior snowballs and significant peripheral vascular leakage. And the OCT macula showed multiple pockets of neurosensory detachment. All of these cases have one common diagnosis of intermediate uveitis. So now comes the question of, what is intermediate uveitis? It's one of the anatomical classifications of the uveitis entities, which is characterized by the main site of inflammation being present in the vitreous, as well as the posterior part of the ciliary body. This disease is usually characterized by the presence of snowballs, plus or minus snowbanks, plus or minus peripheral vasculitis, and we will discuss them in details. The etiological diagnosis of intermediate uveitis can be classified into infectious causes and non-infectious causes. The infectious causes, the ones that we usually see here in Egypt, are tuberculosis, endogenous endophthalmitis, toxoplasmosis, and toxocara. Whereas the non-infectious causes that we usually meet here are sarcoidosis, Behçet's disease, inflammatory bowel disease, and less common cases such as tubulointerstitial nephritis with uveitis, post-streptococcal infection, and we of course have to remember and keep in mind an intraocular lymphoma appearing as a masquerade, the intraocular foreign body following a big history of trauma, and finally pars planitis. So how do we usually approach a case of intermediate uveitis? When we are met with a case that's of young age and bilateral and mostly asymmetrical, then we can think of that might be pars planitis or post-streptococcal infection or TINO. Whereas if the anterior spillover is granulomatous with a lot of snowballs in the periphery of the vitreous with significant periphlebitis, then we can think of TB, sarcoidosis, or MS. In cases of dense vitritis that may actually preclude the appearance of the retina, plus the localized vitreous condensation in one part of the periphery of the fundus in a unilateral presentation, then we have to think of an infectious etiology such as toxoplasmosis, toxocara, or endogenous endophthalmitis. It should be remembered that in toxocara, we might actually see evident vitreous membranes with traction towards the granuloma. If we're dealing with a case of males in the adolescent or the young adult's age with the presence of significant recurrent orogenital ulcerations, then Behçet's disease comes in mind. And finally, in some areas, Lyme disease and syphilis are endemic and should be put into consideration. So what do all of the cases that I presented have in common? We're going to be discussing the red highlights that I presented in the cases. They are all relatively young age, ranging from children to adolescents. Vitritis was 100% present in all cases, even though that in one case it was present in only one eye. The bilaterality of the signs is present in all of the cases, even though if it was asymmetric. Some of the cases had snowballs, some of the cases had peripheral retinal vasculitis. 4 of the 5 cases had mild to moderate manifestations, yet the intermediate uveitis can be severe and not responsive to the initial therapies. They presented with redness and floaters. That means that they were symptomatic. Their systemic history was free, and their workup was negative. And finally, in all of these cases, because they were presented with recurrent redness and manifestations of anterior uveitis, they were misdiagnosed as such. Therefore, after revising all of these points, I classified these patients as a particular subset of the intermediate uveitis, which is called pars planitis. So what is pars planitis? It's a special entity of intermediate uveitis that's characterized by the presence of vitritis, but without the presence of any infectious or systemic cause. The condition is very frequently associated with the presence of something called snowballs. These are simply exudates that are present in the anterior and the mid-vitreous, usually in the lower half of the eye. In some cases, if these exudates tend to rest on the posterior part of the ciliary body or the pars plana, they are called snowbanks. In both of these cases, the histopathological analysis of these exudates, it has been discovered to be formed of collapsed vitreous, T cells, epithelioid and macrophages, glial elements, and some blood vessels from the retina. In most of the cases, there might be peripheral vasculitis anterior to the equator, and it usually affects the venules rather than the arteries. So therefore, pars planitis, when we have a look at the review of the literature, unfortunately, there are no epidemiological studies on the pars planitis here in Egypt, but we find that they are more or less the same from the practice. In any case, when we are met with bilateral anterior segment inflammation in a child, please always look for vitritis, because you'll probably find it, because pars planitis is usually more common than we think. Most of the cases are children, even though there are reports for patients through their 40s, and it has been found that there's a racial difference according to the country. In some countries, the main entity were children, and the others were actually adolescents or even adults. The gender, it differs with age and according to different populations. So for example, in one review article, it has been mentioned that the younger age is, it's more common in boys, whereas older age is more common in females, and there's a racial difference between different countries. All of the cases that I have been following until now are actually females. Up to 90% of the cases are bilateral, even if asymmetrical, and the main presentation is floaters and blurred vision. The spectrum of the disease varies from mild cases in which they may actually be asymptomatic. We find the asymptomatic presentation more common in younger children who cannot complain, even though the older children and the teenagers, they can complain of mild floaters, mild blurring of vision, and some redness. These cases are characterized by decreased AC inflammation, few KPs, a few anterior segment complications like few posterior synechia, very minimal vitritis, and no posterior segment inflammation, complications. Whereas the other end of the spectrum is also visible, and we sometimes see them in practice, where the child presents late with strabismus, cataract, or amblyopia, and the disease is characterized by being more chronic with more severe inflammation anteriorly, resulting in band keratopathy, cataract, and glaucoma, and more posterior segment complications, the most serious of which and the most common cause of diminution of vision in these patients is the macular edema. We also need to monitor the periphery of the retina of these patients because the ischemia can result in neovessels or even disc neovessels, as well as vitreous hemorrhage, and the excessive snow banking can present with localized RD or even retinoschisis. So here are some tips during this history and the examination and the investigation of the patients. Most of these patients are usually misdiagnosed in the beginning as GIA uveitis because this is considered the most common entity of the patients that we have. So the GIA patients, the presentation is usually silent and the eye is completely quiet. Whereas in pars planitis, in most of the cases, the clinical picture is rather symptomatic. Another misdiagnosis that I met in some of the cases was that they were misdiagnosed as seronegative spondyloarthropathies associated acute anterior uveitis. In this subset of the patients, the attack comes usually unilaterally and it's kind of severe with the presence of inflammatory membranes as well as hypopyon. They have an older age and there is significant some sort of joint affection affecting the axial joints. Whereas in pars planitis, the systemic history is free, the attack is less severe, the disease is characterized by chronicity plus the bilaterality. We have a few tips in the examination as well. This is a picture from the literature. This is not one of my patients. There is a pathognomonic sign present that might be present in some of these patients, something called inferior peripheral corneal endotheliopathy. It's thought to be an autoimmune process which affects the endothelium of the lower cornea, and with the presence of sometimes mutton fat KPs at the junction of the normal and the affected cornea, similar to the corneal rejection Gehad line that we see in some of the patients undergoing PKP. In this disease entity of pars planitis, all of the inflammation signs, they tend to be more inferior and it's thought to be due to gravity. So for example, here in the pathognomonic sign shown in the picture, the affection is inferior. Also, the posterior synechia that we see in the patient is usually inferior. In order to assess and examine the vitreous, try to remember that it's not, you can see it actually on the slit lamp before using your biomicroscopy lens. So after the dilated exam, after you check the lens for any cataract, try to focus on the anterior vitreous for the presence of any vitreous cells. And then you can check with the biomicroscopy to check for posterior vitritis as well as inferior vitreous opacities. It's very nice when you see snowballs and snowbanks, but in some of the cases, they might be very peripheral. And if the doctor is not skilled at doing scleral indentation, then a nice trick would be using the Goldman 3 mirror to examine the periphery of the retina. Regarding the investigations, in cases of vitritis without evident snowballs clinically, it's useful to order a fundus fluorescein angiography because it helps in the demonstration of peripheral retinal vasculitis, which can be subtle and subclinical, but very well delineated by the fluorescein angiography. Regarding the workup of pars planitis cases, it's mainly directed to exclude the infectious and the systemic causes, and it's used as a baseline for the future therapies, especially systemic steroids and biologics. There's no special consensus on what to order in a case of pars planitis, but this is like a broad guideline to what we order in order to start treatment. So I order a CBC with differential, a complete metabolic panel, tuberculin skin test to exclude tuberculosis because it's endemic here in Egypt, and in case we start immunomodulatory therapy and biologics later on. I also order the anti-streptolysin O-titr and the beta-2 microglobulin in urine in order to exclude TINO and post-streptococcal infection. We order sometimes the hepatitis markers and baseline blood sugar testing prior to biologics treatment, as well as prior to steroid therapy. And unfortunately, the secondary diabetes in children is greatly underestimated by ophthalmologists. You keep giving systemic steroids and without noticing the complications until the mother reports that her child had started losing bladder control while sleeping again as if he were a baby. Regarding the imaging, I order chest imaging in the form of X-ray or chest CT according to the diagnosis, and we will speak shortly about the role of the brain MRI in these cases. And finally, I always send the patients to a rheumatology in order to exclude systemic causes that I couldn't identify from the history, and especially that these people are much better experts in following up the treatment much better than me. And now comes a special entity of what is the relation of intermediate uveitis and multiple sclerosis, and what is the role of brain MRI in these patients. First of all, uveitis is more common in MS patients, even though there's a wide variation of the percentage in the literature, but the actual percentage is actually towards the 1%. It has been found that MS patients can have various forms of uveitis, but the most common entity was intermediate uveitis. The second point is that MS is more common in uveitic patients when compared to the general population. Regarding the histopathology of the intermediate uveitis and the etiological diagnosis, until now it's not known, but it's thought to be autoimmune with T cell activation, which is the same mechanism that happens in MS demyelinating lesions. Both diseases tend to have a genetic predisposition with being more common in HLA-DR15 subtype. And cases with intermediate uveitis who tend to have MS are usually females. They are older, in their 20s, even though in Cairo University, we have 1 or 2 patients that were diagnosed with MS as young as 15 or 16 years old. The disease is usually bilateral, and the AC inflammation is sometimes granulomatous and can be very severe, similar to what we see in sarcoidosis. The most characteristic thing about MS intermediate uveitis is the almost universal presence of something called significant periphlebitis. The periphlebitis here is quite interesting because they found that in patients with intermediate uveitis who had periphlebitis, they have a higher risk of developing future MS when compared to other patients of intermediate uveitis that did not have periphlebitis. So one of the papers was actually contemplating the thought, can periphlebitis be taken as an indicator for future MS the same way we consider optic neuritis or not? A final entity that must be considered in this subset of patients is that a very famous drug that's used for MS can actually be causing a complication, which is the macular edema. In these cases, we should know if this is related to the drug or related to the intermediate uveitis because it's dose dependent. Once we stop the drug, the macular edema resolves. So to scan or not to scan, there are no specific guidelines to say to make it a universal practice in all of the countries. This title was actually the title of one paper regarding a specific healthcare system in the UK, and they decided that it's not necessary to perform a brain MRI in the initial work of intermediate uveitis case unless the patient fits the criteria of being a female in the 20s and having bilateral intermediate uveitis with periphlebitis, and the patient should have neurological manifestations confirmed by an expert neurologist in MS. And the second indication is prior to TNF-alpha inhibitors, which are the biologics such as the adalimumab and the infliximab, in cases that are very severe and not responsive to the initial therapies, because the biologics are contraindicated in MS because they increase the risk of demyelination. This picture is from the literature of 2 siblings having a family history of MS, and they both had intermediate uveitis, and upon brain MRI imaging, and they also had neurological manifestations, we can appreciate the presence of the ovoid periventricular demyelinating lesions. When it comes to the management of pars planitis, I believe that the most important step is to first categorize the patients according to the severity. Because in some cases, which are actually mild, that we can have complications from the treatment rather from the disease itself. For example, the steroid-induced glaucoma, especially that most of these patients are of young age and very strong steroid responders. When discussing pars planitis, we have to remember two words. It's usually of a favorable prognosis, but a more chronic course. It's in some of the literature reviews, it's described as having the longest duration of uveitis, more than the anterior and the posterior uveitis. We see better prognosis in patients who are females, older age at onset, with no posterior segment complication, and it's worse in the opposite entity of patients having macular edema and peripheral occlusive vasculitis. Their management guidelines, in the old days, they had like a 4 to 5 step guidelines. It's no longer used. So the recent approach is that we start the treatment early and we do not wait for complications to occur. Steroids are the mainstay of treatment in all of its forms, and if the patient relapses after steroids withdrawal or even early on the disease, we can start steroid-sparing immunomodulatory therapy. The most common drug used is the methotrexate, and it brings about good results. And if any of these drugs fail, then in most severe cases, we can use the biologics, but after exclusion of MS. Finally, a point that's worth noting is that the interference improve the severity of the intermediate uveitis in this subset of patients. Finally, we have to keep in mind the role of local therapy, such as argon laser around any localized detachments during vitreous hemorrhage. So it's just a matter of what to treat, not just when to treat. We treat persistent AC inflammation to avoid cataract and glaucoma. We treat cases with dense vitritis due to blurred vision. We treat cases that have glaucoma and cataract, which are usually from the treatment of steroids, cystoid macular edema, because this is the main cause of diminution of vision. We treat cases of ischemia, retinoschisis, as well as vitreous hemorrhage. And now comes, I don't think that anyone can discuss any topic in 2020 without mentioning, is there any role for COVID-19 in this disease or not? Until now, there are no reports for such cases, but I think we should put COVID-19 in any differential diagnosis that happens throughout this year, because it has been reported during the past few months that COVID-19 is responsible for various forms of uveitis. So my take-home message is any case with anterior segment inflammation in a child, search for the vitritis. Intermediate uveitis is more common than you think. Intermediate uveitis diagnosis needs meticulous examinations. Always think of bilaterality and young age and mild to moderate degree of inflammation, then think pars planitis. Investigations are mainly done to rule out the infection and the systemic disease. Watch out for MS in older females, and always apply early proper treatment to guarantee the best prognosis. Thank you very much.
Thank you, Rana. Thank you very much.
You're welcome, Dr.
Thank you, Rana. I hope الأودينسز يكونوا uveitis specialists ولا زانهم يعني أغمى عليهم.
Those are
very comprehensive review of intermediate uveitis تقيل إلا على specialized. طيب أنا عارف إن أنت قريتي كتير قوي في الانترميديت uveitis. لازم اسالك سؤال بقى مدام استفزتيني. قولي لي ليه الانترميديت uveitis بتفضل في البريفرال ريتنا and does not involve the posterior retina؟
هي لان هو المين site of the inflammation is actually the posterior part of the ciliary body. That's why it entangles this part of the peripheral retina. It's just the vessels.
يعني vessels. في هنا خاصيه للبلاد سبلاي هي اللي بتحدد ليه الديزيز is limited to that part of the retina. ايه هي؟
To be honest, I don't know.
طيب يبقى تدوري عليها وتبقي تردي عليها.
طب واحنا يا دكتور جهاد؟
لا ما هو ده بقى.
كده احنا عايزين حضرتك.
هقول لكم. very nice presentation طبعا و very nice cases. هو اللي انا عايز اقوله للاودينسز عشان ما يبقاش الموضوع تقيل عليهم، اهم حاجه in the management of uveitis is to classify the uveitis. You have to, as a first step, classify your uveitis هي anterior ولا هي intermediate ولا هي posterior. You have to train yourself for this differentiation and ده most important. وكل مجموعة من دول لها different group of diseases and different management مختلف خالص. ما يهمنيش بقى what's next دي خطوة تانية، بس أول حاجة لازم نتدرب عليها هي how to classify the uveitis. طيب اغلب حالات اليوفيتس هلاقي فيها anterior chamber cells وهلاقي فيها anterior vitreous cells واحيانا هلاقي retinal involvement. فمنين اقول على دي anterior uveitis ومنين اقول على دي intermediate وازاي اقول posterior؟ اغلب حالات الانتيريور uveitis هيبقى معاها spill over into the vitreous. طب انا اعرف منين ان ده spill over ولا ده intermediate uveitis؟ رنا قالت very important point وهي examination of the inferior retina. فأي حالة anterior uveitis أو supposed anterior uveitis وسع وبص على الانفيريور ريتنا. ما تحاولش تبص على vitreous cells by the slit lamp لأن most probably you will find some vitreous cells لأن لازم هيبقى في spill over from the ciliary body into the anterior vitreous. فdilate the patient and look by the indirect أو by the 90 diopters into the inferior retina. شوف في أي snowballs أي small peripheral granulomas أي deposits على surface of the retina. This will help you classify the cases of intermediate uveitis. لأن الانترميديت uveitis هيبقى معاها anterior uveitis والanterior uveitis هيبقى معاها spill over. لكن عمر ما السبيل اوفر هيعمل snowballs وعمر ما السبيل اوفر هيعمل peripheral retinal vasculitis. Look for the peripheral retina in the inferior part. برضو من الحاجات المهمة في التفرقة أنا لقيت snowballs ومعاها peripheral retinal granulomas ولا لأ. لو الحالة ساركويدوزس أو مالتي فوكال كورويدايتس هلاقي peripheral جرانيولوماس تحت السنو بولز. لكن في حالات البارس بلانايتس ما بيبقاش فيه غير سنو بولز. عاده الريتينال فاسكولايتس في المايلد كيسز بتبقى difficult to recognize without fluorescein. فيهمني سنو بولز without peripheral retinal granulomas. لان لو في peripheral retinal granulomas هتدخلها في الكاتيجوري of posterior uveitis ما تبقاش حاله intermediate uveitis. يبقى انا اول حاجه ببص على الانتير تشامبر فيها evidence of inflammation سيلز وفلير وفي ساينيكيا او ما فيش ساينيكيا بيجمنت على السيرفيس اوف ذا لينس. يبقى انا عندي انتيريور uveitis. طب هل هي انتيريور uveitis وسبيل اوفر ولا هي انترميديت uveitis ومعاها انتيريور uveitis؟ لوك ات ذا انفيريور peripheral retina and vitreous. هتقول لك ده انترميديت ولا ده انتيريور. لو لقيت اي ليجنز في البوستيريور ريتنا سواء فاسكولايتس كوتون ويلز وات ايفر بقى جرانيولوما صغيره اي حاجه في البوستيريور يبقى انت هنا with a case of posterior uveitis. لو معاها heavy anterior chamber reaction يبقى احنا حاله pan uveitis. كل واحده من دول ليها الكوزز الاندرلاينج وليها الواي اوف مانجمنت. ف the most important is to classify your uveitis. طبعا رنا خدت موضوع الانترميديت بكمبليت ديتيلز وباندرلاين كوزز وبكل الكلام ده، وده الجروب اوف بيشنتس فعلا اللي هم مور كومن فيهم اليونج اب تو ذا ايج اوف 30 years كده من اول 5 و6. المجموعه اللي هي من 6 to 15 دول فيهم انترميديت uveitis كتير. الاسيمتري مهم، ساعات يبان انه اولموست يونيلاترال uveitis. كتير من حالات اليونيلاترال uveitis اللي هي على شكل فيترايتس بمايلد anterior chamber reaction unilateral بتبقى pars planitis او intermediate uveitis. You will look for a cause من اللي هي قالت عليهم، بس كتير من الحالات مش هتلاقي cause and it is خصوصا في unilateral cases it's a pars planitis لان طبعا systemic conditions هتبقى اكتر تدي bilateral inflammation. شكرا. وزي ما قلتي طبعا مهم قوي في الانترميديت uveitis البالانس between the treatment and the pathology. لان ساعات الباثولوجي بيبقى مايلد والضرر بيبقى ناتج عن التريتمنت سواء على شكل كاتراكت او على شكل جلوكوما، وده اللي بنشوفه اكتر. يعني بنشوف عيان الانترميديت uveitis عنده مايلد فيترايتس كرونيك وعنده بوستيريو كورتيكال كاتراك دانس او عنده سكندري جلوكوما اوبن انجل من الاستيرويدز، اخطر بكتير من شويه الفيترايتس اللي بينزلوا الفيجن ل 6 9 او 6 12.
دكتور جهاد حضرتك هو يعني كنت لسه عايزه اسال حضرتك ان انا مثلا عندي عيانه ساركويدوزس كل اللي عندها سنو بولز بس لكن ما فيش والانتير تشامبر رياكشن بلس نص، فانا I didn't treat the patient. فهل المير برزنتيشن اوف سنو بولز ده يجستيفاي ان انا تريت ولا ممكن طالما everything is okay والفيجن كويس وانتير تشامبر رياكشن very mild I am justified not to treat؟
لا هو لو ساركويدوزس based على laboratory tests او chest findings. You have to collaborate مع الchest specialist لان الساركويدوزيس هيعمل chronic damage لللنجز.
هم مش محتاجين يتريت، يعني في هايلر ليمفيدينوباثي بس يعني they are not going to treat.
لا ما هو ده برضه disease that affects الانترستيشال tissue of the lung والاكسجين diffusion وعلى الكرونيك ولو جريد وكرونيستي، فلازم يبقى اللي بيعالج سبيشاليزد في الساركويدوزيس او يعني عنده خبره كبيره في الساركويدوزيس، لانه هو بعد 10 سنين العيانه هيجي لها ديفيوجن ديزيز في الريتنا في قصدي في اللنج، وبالتالي هو مشكلته انه كرونيك لو جريد. فانا معاكي انه ممكن ما هو في انديكيشنز فور تريتمنت اوف ذا اي. انا اي دونت تريت الا لو كان الايفكت اوف تريتمنت او الاوتكم اوف تريتمنت از بيتر ذان ذا اوتكم اوف ذا ديزيز. انت هتدي سيستميك ستيرويدز او هتدي لوكال انجكشن اوف ستيرويدز، طب هل في ديمينيوشن اوف فيجن؟ هل في ماكيولار ايديما؟ هل في ليكج فروم ذا posterior؟ ماشي، يبقى هنا ممكن اخد اللوست بوسيبل دوز فور تريتمنت، يعني ادي 10 مللي جرام مثلا اوف سوليوبريد او وانزلها ل5، لكن اي ثينك انها ما دام عندها سيستميك ديزيز she should have some form of low dose treatment for some time.
طب دكتور جهاد، احنا برضو ان رانا هايلايتد important thing كده في التيك هوم مسج ان احنا مش look for it، لان احنا اول statistics طلعناها في عياده ابو ريش we found in very low percent of Planitis in comparison باللي reported في literature، حتى اللي reported في literature في مصر في اسكندريه. فit seems ان احنا the first year we have overlooking the diagnosis or underestimating the part.
بالظبط. The more you gain experience in uveitis, the more you diagnose intermediate uveitis. It's difficult. عشان كده انا اول حاجه ركزت عليها في الاول how to classify uveitis، لانه the more you gain experience the more you find cases of Planitis. يمكن اول سنه او سنتين في ممارسه الuveitis you do not diagnose almost any case of intermediate. برضه بعد ما بتمشي شويه بتبتدي تشخصي الحالات الانيوجوال زي الفوكس هيتيروكروميك وزي الحاجات دي ما بتشوفيهاش من على طول من اول you think انها it's not there او انها كلام كتب، لكن with practice you start to find these cases.
برضه حضرتك يعني في uveitis entities كانت
يعني كان في حاله من المعروضين كان اللي هي كانت عامله فيها ريترو اليومينيشن للكي بيز، كان شكل الكي بيز ستار شيبت قوي. انا قلت في الاول دي احتمال تكون حاله فوكس، واحده من الحالات اللي كانت معروضه.
حاجه كمان في entities of uveitis كانت يعني known ان هي strictly inferior زي الجي اي اي، بس باي براكتس برضه لقينا حالات جي اي اي معاها intermediate uveitis، وبرضه ده كان ريبورتد في الفيتشر، يعني لما رجعنا باكورد لقيناها ريبورتد في الفيتشر.
هو
معاها برضه intermediate.
ما هو ده مغزى السؤال اللي انا كنت بساله لرنا. انت عندك الايريدوسايكلايتس ممكن يكون الجريتست بيردن فيها على الايرس، فتبقى على شكل ايرايتس مينلي، ودي الحالات اللي هي بتبقى فيها انتير تشامبر رياكشن جامده، وفي نفس الوقت ما فيش سبيل اوفر في فيترس وما فيش اولموست فيترس سيلز، مع ان عندي سيفير انتيريور فايتس. ليه؟ لان هنا most of the burden is on the iris. لكن once the ciliary body is involved, الciliary body في recurrent ciliary arteries بتسبلاي معلش التليفون بتاعي في recurrent ciliary arteries بتسبلاي البريفرال كورويد من البارس بلانا، والفينس درينج بتاع البريفرال كورويد is into the ciliary body. فأي inflammation of the ciliary body will involve the peripheral retina. وعشان كده البارس Planitis is limited to this area, the ciliary body and the peripheral retina, because of the common blood supply اللي بين الاثنين. فلو البردن بتاع الايريدوسايكلايتس واقع على السيلياري بودي هتبان زي الانترميديت يوفيايتس، برغم انها كلاسيفايد از ان انتيريور يوفيايتس زي حالات الجوفنايل ايديوباثيك، لكن mainly the burden of disease في السيلياري بودي فيبان لك كانه انترميديت.
حاجه كان يعني ابتدينا يعني ساعات in cases of anterior chamber granuloma ساعات we went for UVM to study the silent area بتاعت السيلياري بودي.
دي ciliary body granuloma في المقام الاول. It's originating from the ciliary body. It projects through the iris. Sometimes it pours cells into the vitreous. تلاقي فيه severe vitritis. واحيانا شفت حالات معاها exudative retinal detachment لو الجرانيولوما راحت على البريفرال ريتنا بتعمل اكسوديتيف ديتاتشمنت. فديس از ا سايكلايتس مينلي، جرانيولوما سايكلايتس.
دكتور جهاد، كنت عايزه اسال حضرتك your experience with the intermediate uveitis with MS patients.
احنا كنا عاملين رساله على الانترميديت uveitis، مش فاكر كانت رساله مين، قرار ولا ايه. المهم يعني احنا لقينا انسيدنس حوالي 3% على قد ما انا فاكر من حالات المالتيبل سكليروزس معاها peripheral evidence of peripheral uveitis او peripheral retinal vasculitis. It's not rare، بس زي ما انت قلتي ان البريفرال vasculitis is usually passed unnoticed. لما بيكون حاله multiple sclerosis you care for the disc and look at the evidence of optic neuritis. You don't examine the peripheral retina, don't look at the inferior retina, so you don't see snowballs and the mild peripheral vasculitis. لو حطيتيها في دماغك you will find cases. لكن it's there. بس it is زي ما انت قلتي، يعني انت اصل الواحد بيشوف كام حاله مالتيبل سكليروزس كاوفثالمولوجيست عشان يبقى الانسيدنس 1 to 3%، يبقى انت هتشوفي كل 100 حاله مالتيبل سكليروزس هتشوفي حالتين يوفيايتس which is not frequent. اللي بيشوفهم اللي هو بيتابع حالات المالتيبل سكليروزس كتير، او اللي هو مرتبط بعياده مالتيبل سكليروزس.
Dr. Gehad, have you seen patients who have been a long time ago on biologics, a long term?
انا لو اختفيت مره واحده هيبقى التليفون طفى عشان بس ما حدش بتقولي ايه لو ايه.
حضرتك يعني you have been مثلا encountered by patients on long term biologics وحضرتك شفت long term complications اللي هي malignancy, demyelination، لان كل اللي احنا بنشوفه so far الحاجات الشورت تيرم، الانفكشنز، immunosuppression.
اصل برضه خدي بالك انه احنا هنا في مصر we don't use full dose biologics. ليه؟ العيان بياخد شويه biologics وبعدين تعجز معاه وبعدين على ما يعمل له قرار وفيقطع له شهرين ثلاثه وبعدين يرجع ياخد، يعني ما فيش الكونتينيوس بيج دوزز دي. لا I didn't see الحقيقه complications اللي ممكن يكونوا شافوا بتوع الروماتولوجي، لكن بالنسبه للاوفثالمولوجي I didn't come across real complications. طبعا الري اكتيفيشن اوف انفكشنز والتوبركلوزز وكده حاجات مهمه، بس طبعا المفروض ان العيان قبل ما يبتدي البيولوجيكس لازم يعمل سكريننج فور تي بي والجنرال هيلث بتاعه يكون فيت يعني.
Thank you very much, Dr. Gehad.
العفو، ميرسي ليكم.
Thank you.
Nice to meet you all.
وأبانوب وكريستينا, thank you very much. ومها, thank you for joining us today. Are there any questions from the attendees or the panelists? Okay. يبقى that's it for
رانيا العيسوي، ازيك يا رانيا؟ هي بعتت لي برساله فانا
نور الدنيا كلها دكتور جهاد يعني.
الله يخليكم، ميرسي ليكم كلكم. يلا تصبحوا على خير.
تصبحوا على خير and thank you all for joining us tonight.
مع السلامه. باي باي.